Okay. Hello, hello. Yes. Okay. Okay, so today we are going to discuss on post-intubation care, followed by care of ventilated patients. In the skills station yesterday, we have seen airway management. We have revised basic airway management and intubation. So, do you remember, after intubation, what should be done immediately for these patients? To start with, you have already intubated your patient, and then maybe at AMD, and then you sent to ICU. What things should be done? What care should be taken to this patient? Let's start with intubated patient, then we'll go to more details on ventilated patients. In terms of making sure that ETT is safely placed, is secured, you prevent dislodgement, you prevent any other complications.
So, now, I think the best thing, if you have intubated the patient, you need to do some of the, can I say, the investigation to make sure the tools are in place. Let's say we have issues with people putting the thing in the brain. So if we do chest X-ray.
Exactly, chest X-ray. And you are looking for what in chest X-ray?
So,
in intubated patient, specifically, what are you interested?
If there are any traumas, like moral trauma, the position of the tube itself?
Exactly, position of the tube. We said that should be at least 4 centimeters above the carina. What else? Position of the patient. How should be the position is?
Depends where the tube is inside. Assume this is the patient.
Yes.
How you bring it ile anga yake ya ventilator.
Okay.
Then you see then you check the saturation.
Saturation. What else? Katika kucheck position, kitu gani kingine ungetamani? Kwa sababu mgonjwa umemturn this side, ungetaka kujua nini specifically? Jana tulisema tuna fix tube hapa kwa kukisia. Tunafanyaje? Ukitaka kujua kwamba tube hapa iko well placed, haiko ndani sana, haiko juu sana, how do we estimate? Diameter of the tube, let's say it is 7 times 3, 21. So here should be at least 21. But also auscultation of 5 points that to make sure that the tube is in place. Okay. You check end-of-tidal carbon dioxide waveform. You secure the tube by chasing X-ray. Head of the bed to say head up, approximately 30 to 45%. What others issue you have to take care in your patient? Before you put to vent, what other preparation, bedside preparation, important in this intubated patient? Practical things. what you make sure they are there. Suction, ambu bag, in case of extubation you have to re-intubate your patient.
What is this?
What is this? For what? Regarding ETT? Pressure of the cuff. Pressure of the cuff. Is it important to measure the pressure of the cuff? Why? Because it may cause in the airway, it may cause swelling, edema. So if you this pressure where the arrow should be to make sure that is appropriate, the green, is it? So you should have suction, you should have ambu bag around, in case, as I told you yesterday, if you want to extubate your patient, you make sure you should have a cut and all equipment for if you want to extubate, you have to have ready equipment for intubation, okay? Now, if you decide to put your patient in vents, what are those key lung protective vent settings, which we have discussed yesterday with Dr. Naima? Important settings in your vents. Yes, you know them. Tidal volume should be. Next. PEEP should be a range. What else? FiO2. Targeting what? Saturation, which should be above 94, or if you have facility to do ABG, above 60, for 55 to 85, depending on type of your patient, okay? Respiratory rate, IE ratio, okay? Imegoma. Yeah. So you make sure your cuff pressure is okay, also to prevent aspiration. You do suction as needed. ABG, mesema ABG is it? After 1 hour, you check tube depth. We have said BVM should be at bedside of your patient. We have already said, and have a plan for ventilator hour alarms. Which alarm would you like to have in your setting? Alarm for what? Which type of alarm? For pressure. Peak pressure, high and low. What else? What alarm would you like to know? Tidal volume. Kama itatokea disconnection, tidal volume low and tidal volume high. What else? Respiratory rate, apnea. Those are important alarm, should be in place. Okay. Mbona? Hiyo hapo. Oh.
Sasa kule.
Okay, so now we continue on care of ventilated patients. We use this mnemonic fast hug. By using this fast hug, inakuwa ni systematic approach of each patient. So it reduces complication and it facilitates, and there is better outcome of the patient. So when you are doing round clinician or even nursing, when you go from patient to patient, you have your mnemonic fast hug. So you make sure that you don't miss any component or element in reviewing your patients. So fast hug stands for F, feeding, A, analgesia, S, sedation, T, thromboembolic, prophylaxis, H, head up, U, ASA prophylaxis, and G, glycemic control. So regarding feeding, you know that if the patient, they are malnourished, that means it's linked to poor outcome. So nutrition should be commenced as early as possible, 24 to 72 hours. And if the patient is malnourished, it can be start even earlier, one day. How will you feed your patient? Patient can be fed with either enteral or parenteral. Which one do you prefer? Or which one is recommended more? Which type? Enteral feeding, is it? Why? What is the effect if we have complete, we don't use oral feeding? What happened to GI system? What will happen? Any organ, if you don't use it, what happened? Atrophy, is it? But also the barrier function may be lost. So it is recommended to start with enteral, but also parenteral feeding, it is associated with complication. In terms of type of food, what component of food should be in the feeding? In your food, mna include chakula gani? Carbohydrates, protein, fats, trace element, fluid, vitamins, and the amount of food which feeding for your patient, how do you calculate it? Depends on what? Basic energy expenditure, is it? Wagonjwa wenu wa ICU hamwalishi? How? How nutritionist ndo na take care? So there are formula, but also there is adjustment, the condition of the patient. For example, if the patient have fever or stress, so to that formula there are adjustment. In that way, they calculate the amount of calorie that should be given to those patients. So during feeding, there is a problem sometimes of intolerance. So if that exists, you should know the signs of intolerance. Mfano nesi anakuambia asubuhi nimemlisha mgonjwa lakini nikivuta tube chakula kinarudi kingi. Kwa hivyo you have to know that, oh, maybe there is a delayed gastric emptying. Au mgonjwa anapata abdominal pain, abdominal distension, diarrhea. So all those signs, if present there, you have to make sure that you intervene. So it is recommended, if there is those signs of intolerance, prokinetics agent can be used. And the common one which we use, that increase gastric motility, but also reduce feeding intolerance. The common one which we use, metoclopramide or erythromycin, is it? Other issue that you have also to check for bowel activity. If your patient is getting their bowel movement is getting stool. If not, you have to give. Do you use lactulose? Of the patient is having diarrhea, you have to rule out what is the cause of diarrhea. Not only food intolerance, but also maybe it could be infection. You have to check out. Okay, the second component of fast tag is analgesia. Sometimes patients are fighting with ventilator. They say, oh, just give muscle relaxant. We don't think of analgesia, we don't think of sedation. Kwa hivyo tunabakisha wagonjwa, that remained and they are psychologically affected and they get delirium. Kwa sababu wanakuwa traumatized. So muscle relaxant is muscle relaxant. It has no sedation, no pain component. So you have to check and assess for pain. There are different tools, scoring tools for grading the different type of pain. The most common one which we use is the critical care pain observation tool, but there are other tools. Now, depending on that tool, then you can have different types of analgesia. We encourage to use multimodal analgesia. You use different agents and in different routes. What are the common analgesic do you use? Fentanyl, opioid, what else? What other group? When you de-escalating? Don't you use paracetamol IV? Yes. NSAIDs? Combination, is it? Okay. So always you have to reassess. You assess your patient, you give analgesic, then you have to reassess. If you have to change, you change. If you have to add, you add. You have to reduce, you reduce, is it? Not one analgesia from day one until the patient discharged from ICU, the same analgesia. No. Sedation. Is it important to sedate our patients? Why? Why do we have to sedate our patient in ICU? To relieve anxiety, Yes. Compliance with ventilator. There are a lot of procedures, monitoring, invasive, they are done in ICU, is it? So to make sure that those procedures and therapeutic measures are done in comfortable way to the patient, is it? But for those patients who have head injury, it also reduces oxygen demand. So sedation is very important. Now, what is the goal of sedating patients? Or what is the target? What are we targeting? Is to make sure that the patient are calm and comfortable. We don't want to be continuously deeply sedated because that is associated with the psychological problem, okay? So how can you know that this sedation is appropriate for this patient? There are different tools that can be used to evaluate, to score the level of sedation, is it? The common one which is used in ICU is the RASS, Richmond Agitation Sedation State. So there are so many tools, but what are the general signs and symptoms of pain? Pain we have already covered. I mean, different components do we evaluate in these different tools? What are components? facial expression, because the patient, they don't talk, is it? They are sedated. What else? Sweating, physiological, that heart rate, blood pressure, lacrimation, movement of the limbs, compliance with ventilators. Other issue is you have to know the medication you are using for sedating these patients. So you titrate the drugs against those scores, but also you have to know the pharmacokinetics of those drugs. Remember that our patient in ICU, they have liver failure, renal failure, so elimination may be delayed. They may have prolonged sedation, so you have to have that in your mind whenever you are using those medication. But also the problem of delirium, that should be treated with antipsychotic. And some medication like benzodiazepine, which are used for sedation, they are associated to have these side effects, delirium. So you have that in mind. Thromboembolic prophylaxis. Why do we, that is very important in our ICU patients? Why? What happened to our patients? They are in a prolonged, they are not immobility, immobility. What else? Physiologically, generalized inflammation. What else? Hypercoagulability states. So all those factors make it's important to prevent DVT and pulmonary embolism. So there are two types of management. They can be pharmacological or non-pharmacological. What are the most common drugs do you use in your ICUs? Enoxaparin. What else? Mwananyamala? Do you have that? How about unfractioned heparin? Don't you use that? No. Moi, do you use that? Okay, sometimes.
Most of the time is the
Clexane, is it? Enoxaparin, okay. You use heparin, Yeah. In which cases maybe?
Okay, so if someone having an existing renal failure, so since it's a low molecular weight heparin, okay, low molecular heparin. So even with the team of the nephrology, they would kind of...
They prefer, exactly.
Yeah, so they would prefer unfractionated because of the large molecular, rather than going enoxaparin, it will further damage, like cause more problems.
Okay.
Enoxaparin requires in a renal failure patient, renal deacimen. Even in another, we need to have, there's actually dose and adjustment that you have to do with the person who has got a renal failure. So heparin is a short acting, it's a little better.
Okay, and non-pharmacological one? What you? Stocking, graded stocking, compression stocking, and?
we have compression stocking. We also do physiotherapy.
IPC, intermittent pneumatic compression devices, you have those also. But most of the time they are used combination, unless patients are contraindicated with the pharmacological, then you can stay with non-pharmacological. Head of the bed, we have discussed that, that prevent aspiration, but also ventilated associated pneumonia. Also, it helps during feeding. In neuro ICU, you see that all patients head up. Why? Reduce ICP. Ulcer prevention. Our patients are stress related, or they have mucosal damage due to also hypoxia, and that increase mortality. So we use PPI and H2 antagonists. What the most common PPI are using? Panto, huh? And H2 antagonist, we used it before. Now, famotidine. We use ranitidine and cimetidine.
Good name.
And glucose control. In glucose control, how frequently are you checking your patient's blood sugar? 4 hourly. And what is the target? 4 to 10 millimoles. So it is important to maintain glucose control because hyperglycemia is associated with mobility, morbidity, and hence financial problem. So apart from those, fast hug, also in some lecture they add BID, fast hug BID. B for bowel care, which I've already discussed. If the patient has constipation, you can use lactulose. If you have diarrhea, you have to check for malabsorption, intolerance, you have to check for infection, you have to check other causes. And if your patient have a lot of indwelling catheters, so you have to reduce on a daily basis. Remove this catheter, remove this, because that's also a source of infection. And de-escalating. So if your patient is on antibiotic, you do antibiotic stewardship, is in sedation, reduce weaning from sedation in that way, okay? And then those are other nursing care which are very important. Mouth care, which we asked yesterday in skilled station. They have to do mouth care 4 hourly to prevent infection. Eye care to prevent dryness of the eye. Pressure care. Our patient, if you don't turn them frequently, they get pressure sores. Patient washing, shaving, security of the lines. Yes? I can't hear you. Central line care. It get it? Speak loudly, I can't hear you.
Central line.
Central line care. Yes. Line security, that's what I mean, central line care, line security. Tangu siku unamwekea, si unaandika pale umeandika siku gani. And then after a week or 3 days, 4 days, you can change it.
Ile mouth care ni kama kawaida, like every time people brush 2 times a day. Ni lazima pia mgonjwa anafanyiwa brushing and all 2 times a day, au unaweza kufanya like the question is that can you do more times au unatakiwa ufanye mara mbili as recommended by dentist? Oral care.
Oral care, you can even do even more. Yesterday they say you can do even 4 times.
So that's the
that next meditation.
Do it 4 times.
4 times.
Just to prevent ventilator
associated pneumonia.
Because we have our ventilated patients are carrying so much of bacteria on the oral cavity. So that's the key source of getting them infections, hospital acquired.
Yeah. Tracheostomy care. That is very important. Una remove ile inner cannula, unasafisha and then unarudisha. Na unapoitoa ile unahakikisha kama ndani ile iko fenestrated or no. Kama iko fenestrated, unabadilisha kwa ile ambayo haiko fenestrated, ndio unafanya suction. Okay. Mouth washing hiyo hapo anasema should be provided this once a shift. Reduce risk of infection, use bath or disposable wipes, you use clean to dirty approach, infection control, shaving, you perform daily or PRN, you ensure that ETT tapes adhere to the skin and promote comfortability, ETT pilot cuff, as we have said, una deflate na inflate. Contraindication, less than 24 hours post thrombosis care on heparin infusion. Contraindication ya shaving. Sleep promotion, as we have said that our patient, they may have delirium, so to minimize, una encourage visiting hours, they were limited, and other period patient should rest. You reduce the stimulus at noises at TV, lights, or encourage day-night routine, aids such as eye mask and earplugs, kwa ajili yote kupromote sleep. Invasive line and dressing should check for patency, if there is any sign of infection, pressure areas, securities, and lines and dressing should be changed according to hospital protocols. ETT care, we have already said. Documentation is very important when you do cuff pressure for every shift. ETT positioning, we have already said that. Tracheostomy care. Whenever you do tracheostomy care, airway management equipment should be there, because sometimes zina block hizi. Dr. Ismail atashare alishapata complication na mgonjwa wake, lakini kwa sababu alikuwa yuko well prepared akaweza kumsave mgonjwa. But if you are not prepared, I always tell you, if you extubate your patient, make sure intubation trolley with all drugs are there. That happens. And that's our handover task before shifting for nurses. Make sure infusion and line are refilled, lines correctly labeled, patient is clean and comfortable, all bags, drainage are emptied, dressings are intact, and lines are secure, because sometimes it happen, shifti moja ikitoka inamwambia shifti nyingine, mgonjwa akachomoa hivi line mtamwekea, yeye huyo anaondoka. Naambia no, make sure your lines are okay ndio unaondoka. Check stock, neat and tidy, and ensure documentation is completed. Any question, addition, comments? Yes? Uh-huh.
The patient had no fever, but the central line is in situ. When are we supposed to remove it or change it?
Is it the patient is needed, do you need that for medication or for what purpose?
The ICU is there for such a long period of time. But the patient has a central line. So how long do we...
Margaret.
So how long do we change
Okay, karibu.
the central line?
We usually after a week.
That's all depends on the, so there is no strict rule on changing, because I would not recommend strict recommendation. They would say 3 to 4 weeks, but if as the doctor said, if this central line is a source of infection, you see erythema around and clinically fevers, of course there might be other sources of infection, Foley's catheter and other things. Consider also changing the central line, even if it is 5 days. Okay? Because central line, it's on the big vessel compared to the cannula, which is on the peripheral. So peripheral lasting cannot last more than 48 hours or 72 hours. Now central line can last for more than even 2 or 3 weeks. Now the central line, what we use, these are PVC, these are plastic, rubber, okay? These are not silicone. So plastic are not compatible with a human thing. Like so, they usually form biofilms of bacteria around it. So that's why it's like it's a not professional recommendation, but this is more of
Practical.
manufacturer recommendation to be changed every 3 to 4 weeks. If it is required for more, so they recommend silicone, or to put silicone, which is permanent catheters or chemoport. So these are all silicone based. Okay, because silicone can stay for years or 2 years. Now our patients, I know not all patients will stay with us for 2 months. Yeah, I know we have that. Not always, not all 100% of all the patients will stay 2 months. There will be like about 5% of them will stay with us for 2 months. So yes, then you can think of putting almost a permanent IV access, or keep on changing the site from here, changing to the left side, change here, femoral. So these are manufacturer recommendations.
Oh, for those patients who are in dialysis.
Yes.
They do the
They do. Yeah.
I have an addition.
Yes.
Good morning.
Good
My
morning.
name is Margaret.
Yes.
I'm cardiovascular nurse from Jakaya Kikwete Cardiac Institute. So concerning with the CVP, so we basically follow the IPC recommendation from the Ministry of Health. So for us, it's 14 days.
14 days.
Yeah, 2 weeks. But as the doctor said, you can change it if there is any sign of infection like inflammation, redness, or you can see if you see the pus. So you can change it if after 5 days. So maximum is 14 days.
But also there are different protocols of taking care of CVC, because the problem with why infection occurs or why it is not does not stay for 14 days and changes is because of the IPC measures we are taking. But at the same time, there is this tendency of giving medicine and leaving it, not flushing it. That also kind of like causes other reaction and then causes problem with the CVC, which makes it like you have to remove it within 4 or 5 days. So I think there's a proper set of what do we call it, protocols or care of CVCs which you need to follow and go through it with your nurses or whoever you're working in ICU, so that everybody is aware of how to take care of CVC when it is in place. Understand?
Okay, you're welcome. Maybe if you want to add something regarding care of ventilated patients. Hello. Una PowerPoint to present? Comments too?
So I don't have much comments. Most of it is well explained by Dr. Asher. So in ICU nurses, we basically follow the first hug in the management of our patient, because when you follow this properly by following the first hug, you prevent most of complications to our ICU patient.
Is it first hug or first hug BID? First hug BID or just
Yes.
first hug BID?
Yeah. And on top of that, there are other issues that you have to consider, which was mentioned on the next slides, like the ETT care or the stomach care. So all this must be followed by our nurses in order to make patients stay in ICU, to be short, and to improve their outcome. So maybe if I can get any the questions from you so that I can explain it very well.
So in addition, what we have done back home in Tanga, this is something which I copied from Bangalore. My sister was suffering from end stage of cancer, and so I was with her in ICU for almost like 6 days. So what they have was that they had put the first hug BID printed out from every bed. So whenever you pass round, you have to look at those things and make sure that when you're doing the round, you look at those, like those are the parameters which you discuss. Not just, sometimes what happens that when we are busy or some emergencies happen, some cardiac arrest, you are still psychologically not still stable from the cardiac arrest, which couldn't survive. So you tend to forget those things. So it's completely like I've printed them out in a hardboard and kept against every bed. So every bed has that printed out and kept, and then like you whenever you do the round, you have to go through those monitoring guidelines. That is something which I copied from Bangalore, and it's working wonderfully in my hospital.
Okay, thank you so much. So I know it was my next talk, but we'll be skipping that talk, but I'll be merging that. So it's more of a comment, and based on the questions that you have brought up, which includes the central line and even the endotracheal tube placement. And do everyone know, I don't know if I just found it here. I found it here. So was kept it purposefully because so anyone knows about this one? Okay, sorry? Yeah, so what's the purpose of it? Yes. So see, this is the thing. It's a very important, and it gives you a direction. It's supposed to stay between 20 to 30 centimeter of water. So why this is really important? Because the patient is tubed in, you have to cuff. I know we just randomly push in like a 10 or 20 cc cuff, and then balloons up and stays there. So it's not the key thing that ETT should not come out. We should not even do harm to the patient. Okay, because I know the nurses are doing fantastic job preventing not getting them bed sores, changing position, putting air mattresses, but also putting attention that ETT cuff, which is cuffed up, should not be so much cuffed up more than 30 centimeters of water. So this is an emphasis to everyone. I know not everyone has in their practice, but this is a key thing. I think Jans has it, so you can contact that guy if he can give you free pieces of this. All right, so another emphasis, I think Dr. Asha and Sister Margaret mentioned, the sedation. Sedation. I know when we do all the heroic acts like intubating the patient and then we put our hand in our pocket and walk away and then leave the nurses like hanging. No. Your nurse is supposed to be your team companion, okay? Don't walk away. You should work as a team. When you intubate the patient, Dr. Asha mentioned that you have to sedate the patient. Not only sedation, we always forget even analgesia. And I don't mean that you have to give Panadol and walk away. Okay, Panadol will not do anything. So it's just put yourself in their shoes, okay, in the tube going in your throat, gag reflex, and it's a whole painful thing. It's a really painful thing. Okay, if you just put your finger in your throat, you feel like nauseous and pain. So go something opioidal medications. There are some non-opioidal, but at least based on their threshold, give them analgesia. Okay, as Dr. Asha mentioned, that at least you can synchronize with the ventilator. So that's very, very important thing, sedation. I know there are scores. Each and every hospital use different tool of how sedation are supposed to be. The more universal tool is Richmond agitation, agitation sedation score. In my hospital, I do not want to confuse my nurses, so I like squeeze down the whole Richmond agitation, made it like 5 scoring system. I know over there they're like -5 and +5 and 0. I don't want to confuse people. I want to give a good care and common understanding. It's upon you guys how you treat your patient, okay? Don't make it complex. Of course, if you want to make it complex, it's fair and well, good. So like I just giving an example, in my patient who was confirmed pulmonary embolism, now the patient was in respiratory failure, which I discussed yesterday on hypoxemic. He was going hypoxemic to hypoxia, starting hallucinating. He was seeing monkeys jumping here and there. I said, okay, this guy is going nuts. Not really nuts, but his oxygen levels are going low in his brain. So what we had to intervene, of course, we gave all the oxygen to buy time, but it really did not help. We had to intubate. Okay, we had to intubate. Did all the things, okay, and since he was delirious, okay, it's not only the sedation we gave, we also gave what medication, what Dr. Asha said for delirium? Sorry? So benzodiazepine is not for delirium, it's a sedation. Okay, and I'll continue with that part, but I just want everyone to let me know what medication you can give. It's easily available. Sorry? Haloperidol. So it's not, I know everyone will have that stigma, oh, haloperidol is only for psych patients. No. It's actually, you can give it to them, or else if haloperidol is not easily accessible to many centers right now, it's more located to psych, so there is a drug, chlorpromazine. Every one of us do have chlorpromazine. I know it's not a recommended drug in many of the critical care, but in a settings, CPZ is more cheaper. Chlorpromazine, the atypical antipsychotic, you can use that. It has a good sedative effect and also antipsychotic. So you just want to reduce them from their whole hallucination, delirium, to calm them down. More advanced drug, expensive one, dexmedetomidine. That's not really available. You can have it in a high-end centers. So yes, good to know, you can have that one. It can work as a sedation and also for anti-delirium issues. So these are the things that you have. And apart from the delirium, okay, the same patient I had, he was given midazolam infusion for good more than 2 days. Okay, more than 2 days. Midazolam is a water-soluble benzodiazepine compared to diazepam. If you give more than 48 hours, it deposits into the adipose tissues and the half-life triples. The patient became so sleepy. He was a 78 years. So, you know, the drug clearance differs to person. So he slept like he never slept before. So he slept, and so it was time to get him out from the van. Early intubation, get them out. So he was not coming out. And he started becoming agitated and everything. He was, so of course you can literally see, say, he's looking at the wall, so that's part of delirium, okay? So what causes? So even benzodiazepine causes delirium, okay? Benzodiazepine induces delirium, what mentioned Dr. Asha. So you have to put in haloperidol, chlorpromazine, dexmedetomidine, whatever is available. Don't restrict yourself on only haloperidol. There are many other options, whatever is available in your center. Okay? So we are all clear on that? Okay? And other emphasis I'm going to put in, okay? That's on feeding. Feeding. Okay? We always forget patient not to feed. Okay, they think like as long as we doctors, nurses, we feed, forget about the patient, they should not feed. They also deserve to feed. Okay, if they cannot eat kuku chipsi like us or wali marage like us, they should get it. Of course, they can't get those solid foods, but they can be delivered via NGT, OGT, or PEG tube. Of course, NGT is the thing that you'll be placing in. Okay, so that has to be placed. And I know some centers do have nutritionists, some do not have it. We have to provide these patients a balanced diet. A balance means they have to have a component of carbs, protein, fats, vitamins, and some micronutrients. In the other centers, I don't know if here others, they have a pre-mixed bag. Okay, South Africa do have it. and other places. Pre-mixed bag means like it's manufactured, okay, which was there in Dar es Salaam back in the days by a company called Fresenius Kabi, but they phased out. So it was pre-mixed bag, of course, very expensive. So you can deliver them with a feeding pump, okay, it goes like 30, 40 based on whatever the nutritionist tells you. Okay, so whatever Dr. Asha mentioned, there is some formula called Benedict equation, basal energy expenditure, 25 times whatever the weight, and you measure, it's everything in the YouTube, okay? I don't want to confuse you all the mathematics, okay? And then, so the energy has to be delivered by carbs, because what I have seen in many hospitals, they rely on the food from home, because some hospitals do not provide food services within their hospital. They do not have kitchen, okay? And like even my hospital do not have kitchen. So we rely on some relatives to bring in, and then our nutritionists do tell us like 1, 2, 3, 4. Some do not have it. So just a message that other centers do just bring relatives, carbs, uji. So the patient will get every 4 hourly or every 6 hourly uji too. So that's carbs. Protein is forgotten, okay? Fats is forgotten, vitamins is forgotten, the micronutrients are forgotten. I know micronutrients, vitamin can be given IV or oral tablets, okay? But these 3 components, carbs, fats, okay, and the protein. Protein is to build blocks, enzymes, because all that protein is being consumed by the antibiotics or the medications. We are so much concentrated on bombarding with bigger bazookas, but we forget about their feeding, okay? So it's really, really important to feed them a balanced diet. Consider yourself, these patients are like us, okay? We have to give them a balanced diet, okay? So the best method is an NGT and not parenteral nutrition, as long as if they don't have any contraindication. Because if you start parenteral nutrition and forget about the GI, okay, the GI becomes atrophy. If there becomes atrophy, oh my God, to rejuvenate that, all the villi becomes a hard work, okay? Because parenteral is just to buy you time, okay? Parenteral should not be a first line, it's supposed to be the last resort, okay? The preferred should be the last resort, okay? So yeah, so these are the second, and what was it? Yeah, I think I just mentioned on here. Did I forget anything? Okay, any questions? Okay, this is very well understood.
Hello.
Hi. So for the next talk, I think will be, yeah. So I'll welcome the next speaker.
Something to change?
This is your mic.
Yeah.
So where's that pointer?
Okay. Hi. You can all hear me? Okay. So my name is Maynard Mekere, anesthesiologist from KSMC. I'm traveled by night, so I'm a bit sleepy. I hope you forgive me if I sleep in between. But I'm going to take you through the troubleshooting. You will troubleshoot me? Great. Okay. So what will you do if a ventilated patient develops a problem which triggers an alarm? So first, you'd want to know, is the problem an urgent, or it's something that you can actually solve it by time? So, you first have to know that you won't be troubleshooting yourself. Keep that in the back of your mind. You don't need to have to fixate it on one task. So if you have a problem and you feel it's urgent, first, how would you know that that the problem is urgent? You need to know on what you're looking for. You are the first and the last monitor. We have monitors, but you, with your clinical acumen, you'll be the one to decide that this problem is urgent or not. Now, if you have a monitor there, if you have a ventilator there, and the alarm goes off, as long as you don't know about it, you won't be able to solve it. Isn't it? So we all agree that we are the main monitor for our patients. So you will actually be able to observe your patient. How is your patient responding? How is the ventilator responding? And how are the monitors showing you? Yeah? So every single time you have to keep that in the back of your mind, that you are the principal monitor of your patient. Because why? You will find your patient in distress, on a ventilator, there's no alarm, and is saturating very fine. You understand what I'm saying? But you, with your clinical acumen, by observing your patient, you will know that this patient is in distress and something is wrong here. You need to solve it. But if you rely on the monitors and alarms, you will pass through, the ventilator is okay, the monitor is okay, and you will leave. But this patient is struggling, is probably compensating. So until some time reaches when the compensatory mechanisms have already wore off, then the monitors now start deteriorating, and now you find your patient desaturating very, very, very fast. And then you start panicking here and there. So number one, monitor yourself, then your monitor, your ventilator, and your patient. So now you know, is the problem an urgent one or not? If it's not, you can actually solve it with time. But if it's an urgent problem now, you'll need help from your colleagues, okay? So that you guys can come and solve in a sequential order. So the ABCD assessment. So you want to look at the patient, you want to look at the airway, is the airway patent, how is the patient breathing, and how is the circulation. But all this, you're required to do this within how much? 3 seconds or 5 seconds. You can do this while you're alone. So you need to have help from others. So is the patient problem or is it the equipment problem? So while you have your team together, you have your nurses, you have your fellow doctors, now you can quickly solve the issue. Yeah? So one of the team can actually disconnect the patient from the machine if it's an urgent condition, if it's an urgent problem, and one of you guys can actually continue ventilating the patient and look, is it the equipment problem or is it the patient problem? Okay? So know your ventilators, know how it responds. So for someone who is going to fix the ventilator, will know how is the ventilator responding. Yeah? So you want to know different ventilators differ with different modes and different settings. Yeah? But you know your ventilator, so you know how it responds and you know how to put the settings right. So now the ventilator alarm goes off and shows that there is high airway pressure. High airway pressure means that the vent is using too much pressure to deliver a certain tidal volume. So the risk for high airway pressure, the complications that could cause, one would be barotrauma, trauma to the alveoli due to the usage of high pressures. Also the change in patient's condition, you find your patient is in distress, and eventually the patient can desaturate due to inadequate ventilation. So on your ventilator, depends on what mode you're using. So you could appreciate here the pressures. So you have set, for example, in a mode of volume mode, you have set your ventilator pressures upper limit to be 40 centimeters of water. And now your ventilator is using more than 40 centimeters of water pressures. So now the vent pressure alarm goes off. Yeah? But what will this cause? Decrease in tidal volume. So eventually a patient will be inadequately ventilated. Now, supposedly you are using a pressure mode. If you are using a pressure mode, it means that you have already set a pressure limit. Remember, you have set to use 15 centimeters of water to deliver a certain tidal volume. So in the beginning, this 15 centimeters of water was delivering about 400 mils. So as time changes, the ventilator won't increase pressure because you have already limited it. But what will happen is the tidal volume will decrease. Yeah? So you have to be very keen with the modes you are using. If it's a volume mode, the alarm of high pressures will go off. But if it's the pressure mode, you won't have an alarm for the high pressures. You might have an alarm for the low tidal volume if you have set the limit. And I know sometimes sometimes when people are troubleshooting themselves, they go on a vent and increase the upper limit so that the alarm can go off, and for them they can sleep at night. So remember not to troubleshoot yourself. So always ask yourself, like, this patient wasn't like this before. Why? What's happening now? So we have seen this diagram, this calculation. I know it would have been better if I draw it here again, but then we don't have the papers here. But I'm gonna take you through. So the balloon component. So you have the this component here, the flow and resistance. I will call it the resistant component. The flow and resistance here. This part from here to here. So the resistance component comprises of the airways. The airways. What your airways right now? How my airways right now on Zippy?
Airways.
My airways right now. Nose, mouth, trachea, bronchus. Yeah. So those are my airways. Yeah? But on a ventilated patient, we're adding ETT, breathing circuits, all the way to the vent. So for a ventilated patient, now those are his airways. The breathing circuit, the ETT, the trachea, the bronchus, all the way. So the resistive component. And then we have the elastic component, the one that it expands. Now the elastic component, this should be our alveolus. Sindio? Our alveolus. So if I'm the ventilator and this is the balloon. Now I'm using pressure to expand the balloon. Okay? So there is a ventilator, there is the resistive component, and then there is a elastic component. So in the beginning, I'm using this pressure. But then as time goes, Now I'm starting to use too much pressures. What's happening? So we need to know what's the change. Is it the resistive component, or is it the elastic component? So the total pressure now, the total pressure that I require to deliver a tidal volume is equal to the pressure on the resistive component plus the pressure on the elastic component. So any of these parts that increases will eventually cause an increase in the pressure that I'm supposed to use. So this is the resistive component. The resistive component is equal to flow times resistance. So if I increase flow, I will increase the pressure in the resistive component. It's new. And if I increase resistance, I will increase pressure in the resistive component. Are we clear? Okay. So how can I increase flow? How can I increase flow? Flow is equal to volume over time. So if I increase volume, I increase flow. If I decrease time, I increase flow. We all clear? Sure. From the equation is flow is equal to volume over time. Volume over time. So T is a denominator, volume is a numerator. So if I increase the numerator, the volume, flow increases. If I decrease the time, flow increases. So on your ventilator, if you increase the volume settings, flow will increase. If you decrease the inspiratory time, flow will increase. So one part, you have increased the flow, you have increased the pressure on the resistive component, and you have increased the total pressure. And then, if you have increased the resistance, how will you increase the resistance? Remember the Poiseuille's law in physics. Resistance, the R power by 4. The radius power by 4. The resistance in relation to the radius. If the radius decreases by a small number, the resistance will increase by 16. You can all go and review it later, but that's the concept. Now, if you have decreased a minor radius, a minor diameter, so how does the diameter decrease? So for your airways, if there is a blockage, or if there's secretions, or if there's bronchospasm, like the diameter was like this, the radius was big, and now you have a smaller radius. So now your resistance component will increase by 16 times. You get me? So that means if your patient has a tubal blockage, airway blockage, due to either mucus secretions, mucus plug, or bronchospasm, will eventually cause an increase of resistance by 16 times. And eventually will cause an increase of this component here, the resistive component. So the pressure here will increase, and eventually our total pressure will rise. So that's only the resistive component. The resistive component. Now let's take a look at the elastic component now. So this here is our elastic component. Our elastic component is our alveoli, which is equal to volume over compliance plus PIP. So our elastic component is equal to volume over compliance. So we agree. And the PIP is the baseline pressure in the alveoli. We all, even the balloon here, if you are empty, it will have a baseline pressure, and that's the PIP. So if I increase the volume, I will eventually increase the pressure in the elastic component. So if I decrease the compliance, I will eventually increase the pressure in the elastic component. And if I increase the PIP, I eventually increase the pressure in the elastic component. So volume is either the tidal volume that you have set, or compliance is either now the patient's lungs are less compliant, which means either the patient ARDS or the patient is breathing. And so now we have a poor compliance of the lungs to actually expand. And then the PEEP that you have set, now the PEEP that you have set, either you have set the highest PEEP, or there are settings that you have kept them causing gas trapping and eventually increasing pressure in the alveoli. So now we have seen also the elastic component. You can increase pressure here. So now you have two components, the resistive component and the elastic component. But then you're not sure which one is the main cause of the exactly rise of the pressure. But in a ventilator, you can do something about it. On ventilators, you can put an inspiratory hold, pause. Inspiratory, pause. So inspiratory pause means that you're holding a patient's breath during inspiration. So if you're holding a patient's breath during inspiration, it means there is no flow going in. So if there is no flow going in, flow is equal to 0, so this component is 0. So the pressure that remains is actually this, the elastic component. You understand? And that, the pressure measured there will be the pressure on the elastic component. So now you have a total of 40 pressure. And then the elastic component, when you have done your inspiratory hold, the elastic component gives you a pressure of 30. It's a very high pressure. So now you know, so the reason could be the elastic component is the one actually having problems here. Because you're having too much pressures, and this pressure here is called the plateau pressure, or the inspiratory hold pressure. But if you have a small pressure here, you have 40, and the plateau pressure is 10, then that means the rest of it is the resistive component. So it means we have a problem here. And that's how we are going to be able to differentiate which will be the cause. Is it the resistive component or is it the elastic component? Using an inspiratory hold on your ventilator.
Hello? Am I audible?
Yeah.
Yeah. So this is a real example that happened. We had a 7-year-old kid who was intubated. Okay? And the peak pressure alarm, which is saying that will determine flow and resistance, was constantly alarming, and it was more than 30. Okay, so immediately we did suctioning, and we checked for the tube if it's kinked, and everything, bronchospasm as well, we were checking on that as well. And the pressure went down. Okay, I'm okay. I went back, and again the airway pressure was alarming again. So now this time, before even I did inspiratory hold, when I did inspiratory hold, my plateau pressure was 20. But that alarm went again of peak airway pressure being high. So I again did inspiratory hold. But this time my plateau pressure was 40. So I have a airway pressure of 40 and my plateau pressure of 40. This means now the problem is in the lungs. So we immediately did a chest x-ray. Guess what we found on that patient? We found a bongular pneumothorax. And we had to do needle decompression and chest tube placement, and everything was fine. So this is why the alarm is important. And every time you get an airway pressure alarm, make sure you do an inspiratory hold. If you don't know how to do inspiratory hold, make sure you go out of here knowing it.
Yeah.
Okay?
Yeah.
All right, thanks.
Thanks for the wonderful scenario. So on top of that, whenever I put patients on a ventilator, the initial start settings are very crucial for you to like note them down, know your patient. Whenever this patient goes on ventilator and keeps on changing, you don't have to wait for the alarms. Just ask yourself, you are using this pressure in the beginning. Why is this pressure now going up to this? Yeah? The recommended pressures, plateau pressures, will be less than 30. But on any patient, normal patient physiologically, the pressures are usually even less than 15 when you start ventilating them. So you shouldn't wait until they go up there and start asking yourself. But it's a very good scenario. You had a question? Yeah. There?
So my question is, if you don't respiratory holes, there's no flow, because there's no volume going in the patient.
So you are holding a patient during inspiration. So you are restricting the flow.
After inspiring, before inspiring.
During inspiration. Yeah. That's where you put a hold. So the vent will measure the pressure at the end of the respiratory hold. So the pressure that is inside the alveoli, that will be your plateau pressure.
But my question was
The volume in the pressure component no. Yeah. So we have talked about inappropriate settings. Yeah, you all remember the first resistive component, the tidal volume, and the inspiratory time. We have talked about the resistance in the HT tube and the bronchospasm. We have also talked about the compliance. Could it be the patient, could it be the chest wall or the pleural, the pneumothorax from the scenario. You see, this was the pneumothorax, yeah? You can see from an X-ray. I've talked about all this already. Okay. Inspiratory pressures. Great. So that's basically it when you have a high airway pressure alarm. So to conclude is that there is a ventilator, there are the breathing circuits, there is your patient. One of them could be the cause of high airway pressure. Okay? And when it's an urgent situation, you always have to have your help. Don't have a task fixation. Most of you will find yourself fixated on a ventilator while the patient is struggling and in distress. And the patient could actually code while you're on your task fixation. So I want you to view the surroundings in a 360 angle. Yeah, 360 angle. Like, get yourself out from the situation, examine your patient, yeah, and solve the problem. Either is it the vent, is it the breathing circuits, is it the patient? Have your team deal with the patient, disconnect on vent, go with the back valve mask with high % oxygen, while you are setting your vent and you're seeing and you're actually looking for what could be the reason. Yeah? But also, if it's not an urgent situation while your patient is on vent, now diagnose what could be the reason. Is it the resistive component that is rising, or is it the elastic component? And if it's the elastic component, then ask yourself what's happening. Is it the patient is breathing against the vent? Do you need to sedate him? Or is it the patient now is worsening because of the IRDS. So should we have a CT scan chest or an X-ray chest? Yeah. Sir? Okay. Hypotension. Hypotension on a patient on a mechanical ventilator. Seeing through your monitor, the patient now blood pressure is dropping. So it could be either between the two. Is it your ventilator machine settings, or is it the drugs that you're using, the anesthetic drugs that you're using while you're keeping your patient comfortable in a ventilator? All this could bring about hypotension of your patient, or the diagnosis that the patient is in. Maybe the patient is sepsis, is septic, or the patient had a neurological injury, and now the patient is becoming hypotensive. Yeah. But then your ventilator can actually cause hypotension. How? Decrease in venous return. So physically, physiologically, normally, pressure goes from high pressure towards low pressure. So here, my inferior vena cava goes, pours into the right atrium. It's clear. So when I breathe in, I create a negative pressure in my chest. That negative pressure causes a pool of blood to come towards your right atrium. Now, so now your patient is on a mechanical ventilator. The ventilator is providing a positive pressure. So now my chest is having a positive pressure, not a negative pressure. So now it becomes hard for actually the veins to return back the flow towards the right atrium, and then you get a decrease in venous return. So a decrease in venous return eventually causes decrease in cardiac output and hypertension. Okay? So the more you increase the pressures in your chest using your ventilator, either by putting your patient on high PEEP, or a shorter inspiratory time, or a high respiratory rate, creating an intrinsic PEEP, or causing gas trapping, will eventually cause more cardiovascular instability towards your patient. So, again, your drugs could be the reasons. Our anesthetic drugs, either you're using propofol, midazolam, whenever you use them as infusion, could cause hypotension. So you always have to be careful when you're dealing with such patients. So most of the times when you have a critically ill patient, we normally tend to avoid drugs that actually cause cardiovascular instability. Yeah. So we have drugs here, dexmedetomidine, which is very expensive, but then each two can cause hypertension. But then when you want to put your patient comfortably, you could use your analgesic infusion, either fentanyl infusion, and your patient could be very, very calm with it. And if not, you can actually add some boluses, either use boluses of midazolam or ketamine. But when you have a critically ill patient and then you put them on an infusion, you always have to be very, very careful with your cardiovascular instability or deterioration. Dynamic hyperinflation. This is when either you are hyperventilating your patient, either you have put them on high respiratory rate, or you're using high tidal volume. So now your patient is breathing a shorter time for exhalation. So eventually, your lungs keeps on expanding, and now you have gas trapping inside the alveoli, and eventually a very huge positive pressure inside the alveoli, and eventually hypertension. Hyperventilation, we use it on certain situations. I don't deny it, we use it on certain situations, but then it should be given as a dose. yeah, timely manner, and continuously observation. You can keep on your patient like that for 24 hours. So, tension pneumothorax could be very rare, but then it's there. Now, when you have a patient with high air pressure, and now the cause was tension pneumothorax could also cause hypotension. Desynchrony. So desynchrony just means the patient isn't actually complying with your ventilator settings. So the patient is struggling and you have kept the patient on such settings. So look for and treat the cause. Why is the patient agitated on a ventilator settings? So a complete paralyzed patient on assist control mode, he will do just fine. But now you have a patient who is not paralyzed, and then you are trying to wean them off. You put them on synchronized mode. Patients can actually be very comfortable in synchronized mode compared to the control modes, yeah, when they're in a bit of sedation. But then you have some patients who won't comply with the synchronized mode, and they can actually be very comfortable in the supportive mode, like pressure support, because the patient, they're breathing themselves. So number one could be you have put them on a wrong mode. But also, when you put the patient on pressure support mode, and then this patient is still, the lungs are still worse, so you still need some time to actually let them heal. So you can then add a sedation component. Sedate your patient, make your patient comfortable, then you can put on your synchronized mode. So mode of ventilation could be an issue. So try and look the best mode for your patient. And then the E ratio. Always remember that. Whenever you are adjusting your respiratory rate or your inspiratory time, always be keen to know the IE ratio. Most people forget the IE ratio. They can come in and adjust the respiratory rate. Yeah? And now you find the IE ratio is 1:4. Or you can even put an inverse IE ratio without you knowing. But when you are keeping an inverse IE ratio is being used in some situations, in clinical situations, for example in ARDS or whatsoever, but then it's a dosage. It's a dosage because your patient would be comfortable with an inverse IE ratio. That's not normal for us. So you need to either give him a sedation, but then you doing that unknowingly, that's what we don't want. We want you, whenever you adjust the respiratory rate, whenever you adjust the inspiratory time, always look for the IE ratio. And the ventilator will show it to you. So, we'll show it to you. And there are some very small numbers that they will keep on changing. Look for them and always balance it. 1:2, 1:1.5 for small kids. Yeah? Triggering. Flow and pressure. Our triggering could be very complicated as the way you see it, but when you get used to it, it will just be simple. So triggering is that either it's the patient triggering or the ventilator trigger. But here we are talking about the patient trigger. Patient trigger, we have two types of trigger, flow and pressure. So it's either you have set flow or you have set pressure. So different vents, they differ on the trigger modes they have. But we recommend the use of flow triggering. It's very sensitive and actually easy to use for your patient. So, consider sedation. I already talked about it. When you are worried that your patient hasn't actually healed your lungs. Yeah. So, on summing up, your patient is desaturating, but then it's not that urgent, but then your patient is desaturating. So now you remember the oxygen component, things to increase for oxygenation on a ventilator. What? FiO2 and mean alveolar pressure. Where mean alveolar pressure we could increase tidal volume or PEEP, or inspiratory time. Yeah? Okay. So now you have set your FiO2, you have increased to 100, but still your patient is desaturating. So now you want to see, is the chest moving? No. So then you disconnect the patient, you manually ventilate. Yeah? Is it easy to ventilate? Yes or no? So yes, then the ventilator could be an issue. Yeah? Check the ventilator settings. But if it's a no, it's difficult to ventilate your patient with a back valve mask. Then it means the patient or the EDT, there's an issue. So, and then you can either do suctioning or change of the ETT, or you can do your inspiratory hold, then do your chest x-ray to actually see what's happening to your patient. Desaturation, chest is moving on a ventilator, yes? Then examine the patient. Look for endobronchial intubation, and this is very common. This is very common. Actually, it has been found that highest percentage of patients deteriorate in the ICU after intubation and post-intubation care. This is why this is common. The set depth. The set depth. So whenever someone does either HT protocol, suction or whatever, or the patient is very agitated, just a minor change of depth of the ETT could actually cause desaturation of a patient. The tube can actually slip in very easily towards your right side, and can cause endobronchial intubation. But now, at the beginning where your tube depth, you recorded it to be 21, and now you find it to be 24. And then your patient is desaturating. And the way you desaturate, because mind you, you are excluding all the other lobes. You're excluding the left side. So this is very common. Endobronchial intubation is very common. So always make sure timely manner assessment of your tube depth, and bilateral air entry. Pneumothorax could be the reason, collapse, edema, or bronchospasm, depending on the diagnosis that you have. So, take home note, remember, don't troubleshoot yourself. Never troubleshoot yourself. Don't task fixate. Call for help. Okay? Call for help. It will help you. And I'm telling you, kwa sababu even us, at Airway specialist VP, because I know this, when you're called in and then you know that you're the last to have a say, and then umefreeze, unafanya analysis ya muda mrefu, si unaelewa, because now utamuuliza nani? When do the last? But you're patient, and that's why we have this algorithm to actually help us, the cognitive aids to help you, so that you shouldn't task fixate. Now we have to spend more time on the analysis of the problems. So always take that in note. You have any question? Any addition?
I think you are well summarized, so it was a very good presentation. And I believe you can see the application of physiology in troubleshooting mechanical ventilation. So the more you look at those numbers, I feel if what I do, if I have like limited number of patients, like in the private hospital, normally I would go every hour. I'll check my vent, I'll check the graphs. There are so many things to learn. This is just basic. There's pressure loops, there's flow volume graph, so many things that can tell you. But it's your way of how much are you motivated to learn all this. Let me tell you one thing. It's not just emergency or critical care or anesthesia who needs to know this. Even someone who's aspiring to be a surgeon, a family physician, everyone needs to know these simple things, because your end goal is to save a life at the end of the day. It is not just to do OPD clinics or so forth. So everyone here, I know it's in critical care, but teach this to your fellow colleagues as well. Yeah?
Thank you. Dr. Ram, next.
So who's the next presenter?
I just
Yes.
Would you like to get breakfast?
Oh, breakfast. It's just breakfast. So basically, this is mute.
Okay.
Hello, hello. No. And then again, unmute. Nice. Hello. Hello, 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 hello. Hello, 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 hello. Hello, 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 hello. Hello, 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 hello. Hello, hello, hello. Hello. Yeah. Yeah. Yeah, central line, okay. Muongezea nini?
Yes, sir.
So kama una like 5 minutes unawasha kama train pale
Uende mbali na Hebu funga hishi.
Okay. Vipi, mnaonaje? Taarifa inafika. Kwa hiyo tulikuwa kwenye patient journey from the beginning of a patient who comes in with respiratory failure. We went ahead to have this person in variety of care where we gave oxygen. We went up to high flow oxygen. We went into non-invasive ventilation, and we found that this patient actually is not tolerating. We decided to intubate the person. The person went into the ventilator, and we looked into how we can troubleshoot various issues that may arise. And we went into ICU or emergency and ICU housekeeping. We went through the first hug. But you can see there's a lot of information has gone through this person. Dr. Moise managed the airway, intubated the person. He left the person in ICU. They were troubleshooting, came around, nurses were able to manage. But this kind of information has to be passed on from one practitioner to another, and therefore communication and handovers becomes a paramount information that we have to discuss. What does that mean? It is simple. It's just a transfer of information. Not only information, but also accountability and responsibilities. But when we transfer, it's not only, Dr. Moise is leaving and said, Dr. Chunga, I left 2 patients in ICU, and he leaves. This is very important if we are looking at quality of care. And it forms a bigger part of what we call clinical governance. Ideally, effective handover will deliver accurate information in a timely manner, will help in safekeeping of that patient. It will reduce communication errors. Sometimes we just say, give that person adrenaline, but actually you meant no adrenaline. You give that person medication, but medication, there are quite a few medications that a person in ICU may be having. So effective communication in the form of note keeping, in the form of verbal, they are always equally important when you're actually transferring care from you to another. And I'm not only speaking about that patient in ICU, I'm speaking about that person that we may be transferring from EMD to the ward, or from the ward to ICU. All this information that were in your custody, they are important, that can be transferred to another unit or another department or another team so that they can care on this patient. And it may be just immune suppression, immune status. It could just be like that. The person is HIV positive. That means a lot when it comes to choices of medication, what needs to be done, and therefore communication is important. And therefore, an effective clinical handover can lead in discontinuity of patient care. And that is what has been done in the EMD. If information has not been passed on the patient, for example, the patient said, guys, I don't want any CPR. Do not do CPR on me. If you do not write that information, you do not pass on this information, the person comes to ICU, collapses, you start CPR. This person can actually lead to malpractice claims, because I said, and when he's talking to you, you're talking on behalf of the hospital. So therefore, we don't expect something done in the EMD will be very different from something done in the ICU. And sometimes we had those kind of situation where people say, no, don't take me to the ward. No, sometimes the main issue will be how we communicate and how we transfer the care. Where does this mostly handover happens? It happens in a variety of clinical points that a patient passes. It could be during the shift change. We understand nurses change, doctor change. And sometimes you can see when a particular nurse is around, when a particular team is around, or when a particular doctor is around, a patient gets a different set of care. And they will say, I wanted that nurse, I want Dr. Ismail to be here. But there are other doctors. The reason being, handover has not been given appropriately. Someone feels that this is not my patient, because handover gives the accountability to another physician or another nurse, and by knowing the information of what the patient needs, then it's easier to handle that patient in the way that they want it. Clinician updates, transfer of care to another patient department or healthcare facility, on admission, refill and discharge. And here, we have to understand the information may be different. When just one handover from one physician to another in the same hospital, it's going to be mostly clinical update. Guys, today this person, we changed from vancomycin to meropenem, or we added this medication. If the person is known by Margaret, and so another nurse does not have to know a lot of information, but everything that has happened through that day needs to be known. But when you are sending the person from Muhimbili to Hindumandali, or from Hindumandali to Muhimbili, then a different set of information that is needed. All the information is being transferred to Muhimbili. It means we need to, all the information you have collected to the patient has to go. It's not just a discharge paper that says the patient with pneumonia is coming to you. It's not only that. All the information that the patient gave to you is important to be transferred. The other important information is to alert staff member on deteriorating patients. These are kind of information. Dr. Moise is head of a unit here, so sometimes he has left a patient in a good condition. When a change of condition happens, he needs to know, because probably he felt that this person may not need intubation today, or probably this person may not need to be to go into invasive ventilation, and he would like to go maybe non-invasive. So letting him know that there is a change or the patient is deteriorating will make him make a quick decision on what you want to do in the coming minutes. Meaning, there are ways we can give these handovers or this clinical information. One is by using a standardized approach. This is one that when we do our clinical round in the morning. In the morning, every day, maybe it depends on your protocol. There's some ICU, they do, depends whether it's closed or it's open. They may do rounds in the morning and in the evening, or they may do quite often, depends on the protocol or how the ICU works. But in some situations, you may want just to update a doctor or to update a nurse or your colleagues when you're changing the lift. So the type of information is different. So the multi-system approach. In the ICU, a patient does not have only one system problem. You may have a different system. The first hug that we are talking about is one of those situations that you can see. You are giving feeding. Feeding is what? Is a GIT, right? So GIT has to be assessed from what you give and what comes out. So you have to say how much you gave and how much is coming out. It's very important. Whether it remained, how much remained after giving the feed is very important to be communicated, right? Whether the person is passing flutters, whether the person is getting actually bowel movement is important. And when the surgery hasn't done or surgery has not been done, then it also gives a little set of information. So GIT is being covered, right? What about respiratory? If you're talking about giving someone oxygen, talking about giving someone ventilation, it means you're talking about a whole set of airway. So respiratory system. you have to speak about it. Even if it does not have any issue, you have to mention respiratory system. Not only that, neuro, CNS, from the pain is part of the CNS. So if you're giving analgesia, it's part of the CNS. If you're giving any sedative medication, it's part of the CNS, right? If the person is delirious, it's part of the CNS. So you can see neuro, respiratory, it goes into cardiovascular, you go into renal, because we're not talking about electrolytes, we're talking about inputs. The catheter, this is the renal system. Your electrolytes, part of the renal system, so it means it has to be included. Then you go into sepsis. Sepsis by itself, in ICU, every day we're monitoring to see if this person is developing any sepsis. That's why we're checking temperature, we're checking VAP scores for the invasive catheters. We're all looking at that, looking for if the person has developed sepsis or if there is anything different. So we can see a multi-system approach is very important when you are actually documenting ICU notes, or sometimes even for the person who is being admitted, you have to go through because it's not one organ that is being affected. You can combine verbal, visual, and written communication as part of that. And mostly, as I mentioned, we have to go through from head to toe, assess the person. The number one issue that we have seen for the new generation physicians or new generation teams that comes in our teams, we don't like touching patients. Every patient who comes to hospital, they feel loved when they're being touched. And the only way you can touch them from head to toe, you will always find something. If it is not about their mouth, maybe by just assessing the person, you may see something about oral, and therefore you can recommend someone to get something from the dental department. By just looking at the skin, you may find something that, and I can tell you, some of the clinical signs of systemic illness come on the skin. So by just looking at that person from head to toe, you will find out. But nowadays, you will see someone doing ICU round, a person is being covered by a sheet, they never even open up to see that person. Always, every day, a person must be looked from head to toe. Every area has to be looked and documented. I don't know if this is not been done. Dr. Rina, in your patients, you don't do head to toe every day in the morning?
We do,
twice a day. Right? Dr. Ismail, what about that?
We do once a day.
Yes. Guys, unclothe this patient. We need to see every area, wherever they see, because sometimes it could be just development of a bed sore. That bed sore needs to be assessed. That bed sore needs to be looked at what? We need to check to turn them around when they turn. Of course, nurses do, but if nurses have not communicated to the doctors, we may not know. But even as doctors, we have to look in those patients so that we can make informed decisions and change of care. Sometimes, even myself here, I may be having a patient in my EMD, and I would like this person to go to Dr. Ismail. How I communicate matters. Now, Dr. Ismail, I've got a patient with pneumonia. Yes, it's a very good information, a patient with pneumonia, but this is not enough. It's not enough for Ismail to think of, to evaluate to see that this person who is coming from Dr. Chunga at Malanyamala or Dr. Chunga at Saifi, I should provide a bed. There are ways that you can communicate, and the best way is have a checklist that you can go back. And one of the things, and this has been advocated with WHO. WHO has got this tool that also is advocating. I think Ministry of Health as well, they are probably using the same tool, the SBAR tool. The SBAR helps in a clinical communication when we as physicians or as staff to communicate situations, background, assessment, and recommendations that may be needed for that patient care. Of course, when I hear someone calling me about a patient, I want to know who are they, because it will help me into deciding to see even the type of information, the quality of information depends who is talking. State who you are, state your role, state where you're calling from, right? The example you can see, my name is Dr. Chunga. I'm a major physician calling from Shifaa. I would like to speak with you about a patient with pneumonia. You see? So first, when Dr. Ismail hears about that, first he knows who is talking, where he's talking, what about we need to talk about. So that's very important. Situation. Speak about the situation that we're having. We had this person who was admitted in our ICU. We extubated, but today, suddenly he deteriorated. We think of re-intubating this person and release an ICU bed. It means you're already given a background information that's adequate enough to make a decision. Whether you are in at EMD, to the ward, or from the ward to ICU, these are kind of information they want to know. I'm calling you about Mr. So-and-so, who we probably know about it, and especially for the nurses or for the doctors when the doctors are away. Dr. Ismail knows how many patients are there. Even now he's here. He knows exactly how many patients are there in the ICU. And probably we've got a patient who is actually in the second month now. So he knows exactly. So he needs, if you want to update the person, of course, he knows about that person. Speak about the age and the bed number if he knows about that person. And speak about what is the situation. That tube has, the patient actually self-extubated. When he hears that, if he has got an ambulance, he will come with an ambulance. You see, so it's very important to speak a little bit about that background of the situation, and then go back to background, as I mentioned before. Then assessment. State the information relevant to the current situation. What exactly has happened? The person tube went out, the person is actually now in cardiac arrest. Right? So Mr. Smith had a GCS of 15 and I assessed him an hour ago. His GCS now is 12. Right? Pupils are equal, right and left, right? His ICP is 10 and his vital signs are within normal limits. By having this information, Dr. Asha, who is a neuro anesthesiologist, when he hears those kind of information, he knows, because she knows how much target he needs for ICP. Thank you. Recommendations? So what do you want me to do at this hour in the morning? This is 2 o'clock, you're calling me about this patient who I know about. What do you want me to do? Well, you want them to come, or you want them to come to what needs to be done? This is very important. So this is one of those case studies that we have done about SBAR, very important. And basically it's all about what I mentioned. The other part of communication is not about us as physicians, but it's about how we communicate to our patients. I can tell you more than 60% of patient problem is in the head. And it's because of how we communicate. It could be a simple malaria, but how you communicate to the patient. And when you're talking about patient, it's not about that person who is ill. There's that person who is ill, and there's the other person that their family that are taking care of that patient. Communicate with them both. So that one provides support and comfort, promotes satisfaction, establish support and knowledge base, and establish relationship. And most important, it encourages the participation in a clinical making process. If the family doesn't know, if the patient doesn't know, even if you're saying, oh, we need to have a surgery, why you want to do this surgery? But if you have communicated, you know what, we have seen based on the abdominal pain that you're having, we have done this, we have done that, it looks like you may be having appendicitis, or you have appendicitis. Yes, acute appendicitis can be treated with medication early, but at some stage, depends on the clinical deterioration or clinical changes, we may wish to do a surgery, and that has come. We see your stomach is having peritonitis, and because of that, a surgery needs to be done. When you transfer this information, because even the patient Google, even the patient have got another doctor who is their friend they can speak about, but when you send the correct information, and the information, and you can set expectation through the course of treatment, then it is easier when you give them advice for them to accept or make an informed decision. Poor communication, what's the impact of it for us? Increased anxiety. You are talking about a patient who have been treating for many months. Now we're talking about something that actually is going to be debilitating. There is something, so it increases feelings of vulnerability and powerless. Dissatisfaction and lack of trust. And this is the last thing that we don't want us to miss. Our patient must trust us, because we're going to make a lot of decisions. Some of the decisions about taking a significant part of their body. So you must make sure that trust is never lost. The best way to do is by giving them information in timely manner and at the right moment. All right, so those are kind of the things that happens in our ICUs or in our care. These are kind of stuff that happens. How we establish communication is simple. Acknowledge the presence, acknowledge their concerns, acknowledge things that happen. Introduce yourself in position and everything. I think this one is already been covered. All these are checklists of how you actually speak with the family. Usually don't be narrative. You speak one information after the other. Have some pauses when you're giving this information. These are the techniques that go along with speaking with the family. Body language is very important. Be prepared with the information. Have the file. Review information. Don't miss information that is actually important, because coming back later, speaking the same thing can be different. But know the patient well. Sometimes I've been a patient sometime with my family, but the person that is meeting is giving me information, that exactly is not up to date. It's telling me about 5 days ago. While yesterday, things changed. And you understand, in Tanzania, our patients can be ahead because they'll be speaking with Ismail, will be speaking with Moise, will be speaking with whatever. They know a lot of information. So when you're speaking with family, make sure you have that information. And if, of course, for ICU, tended to have or to establish a culture of family conference after the round. Some patients need to have a set a family conference, because the way we do in here, we may have one patient with different people making decisions. So the best way to do is to have family conference. Ask them to bring those important others that can be part of that meeting. Speak with them, hear out, set a goal of care. And then it's easier to update from there. All this information will help you. Will help you in managing many things, managing weaning, managing extubation, or sometimes stopping of care, because of you have explained, you have known the expected, you have set the goal with the family, and that's very important. I think Dr. Asha and Dr. Ismail have spoken about these things that will promote resting of patient by setting visiting hours. And if there's any question, please, I will have my colleague to answer the questions. Any questions? Any area of clarification? Five minutes.
Clarification, just insisting the importance of feedback and family. I will share with you one scenario. Yes. You know, it's our EMBA, it's Moi. Alikuja mgonjwa mmoja top high profile patients. Kufika pale mbele yake kulikuwa na wagonjwa kama watatu. But all of them, they needed to be done the same procedure. But you know that people sometimes are very clear. So when she waited for the procedure, the first patient went in. The next patient went in. The third patient went in. Now it comes her time. She waited for 8 hours. And then she started thinking, why they don't let me in? What's the problem? They want from me. So she started calling the other high profile, and then they are calling me. Why the patient is not going to theater? What's wrong? But then I found out, I know that the sterilizer was malfunctioning. So all those equipment which were used for both factory patient, they need to be sent somewhere else for sterilization and then come back. But all these problems, what is the source? Because the team who are there on call, they just didn't give feedback to the patients. That's the only thing. So when the family was informed and we start calling them and explaining to them, then to Mama Samaha, then she understood. And when all the equipment came ready, then she took to the theater and everything was okay. That's why I want to insist. Feedback, communication to the patient and relative is very, very important. You will avoid a lot of problems by doing that.
Good. Okay, so that's very loud. All right, so I'm just going to talk to you about transport of a sick patient. How many of you have been involved in transporting an ICU patient or a ventilator patient before? You know, going outside your ICU or outside your... Yes, you have? Where have you gone to? CT scan? Anybody else? Yes? A few of you. Any of you have been outside of hospital to a different hospital? No. So all of you have just transferred patients in your own hospital. Okay. All right. So it's really important because often, obviously, you have a sick patient that you're in your ICU, that you've got all your support around you, you've got your familiar environment. So when you have to take a patient outside of ICU, you have to have a good reason. Okay. And often it's because they need some diagnostic imaging like a CT scan or some sort of procedure like go to theatre or go to another hospital that provides that level of care or that extra procedure that you don't have in your own hospital. Okay, so there has to be a good reason that you're going to take this patient out of your environment that is now safe and familiar. Okay, so we're just going to go through how we would prepare for it. And essentially what you might encounter and how you need to kind of troubleshoot along the way or just try and prepare for what might happen. Okay, so the main reasons I've talked about, that's why people would go. And we're going to talk about, if I'm going to take a patient, I need to know that me taking a really sick patient, let's say we've got this patient who's got, come in with a headache, unconscious, we think has got a bleed in the brain. We've had to intubate because of low GCS. Okay, and they're in my ICU now. So, how many of you think the CT scan is really important and is going to change what happens to the patient? Nobody? Nobody wants to scan this patient? There's a few of you. With the
It's important, but I know the symptoms like if you hemorrhage, in your sitting here, I don't know what they're going to do.
True. So essentially you think that if it shows you something that you can't do anything about, what's the point in doing it? Is that what you're trying to say?
No, I'm not trying. See, it's important to do it, first of all, to have the diagnosis.
Yes.
We want to confirm if it is that, and perhaps guiding us on management. But I'm trying to think I'm in Kilomero, that's where I've been working.
Yeah.
And then after that patient, to St. France, that is maybe 100 kilometers from the...
For a CT scan?
Yes.
Yeah. Oh, wow.
You
Okay.
see all
Yeah.
those
Yeah, you have exactly my point. So you have to weigh it up. What is the risk of taking a patient 100 kilometers away to do this scan versus what am I gain from it? If I gain something from it, that's going to change this patient's outcome. Yeah? If it's going to tell me it's a hemorrhage and I think it's a hemorrhage anyway and I can't do anything about it, it's not going to change what happens to the patient. Do I need to do all of this for that patient? Put them through the risk of an ambulance in the middle of the road somewhere with somebody who may not be trained to even take them. So that's the kind of decision you have to make every time you take a patient out of ICU. Even if it's in your own hospital, they could be on a lot of noradrenaline, they could be really hemodynamically unstable, or they could be on a lot of oxygen. Moving them on a transport ventilator, which is never as good as your ICU ventilator, means their oxygenation ventilation could get worse. Is it worth doing this scan? So you have to really think, is the risk worth taking if it's going to benefit my patient? Okay, good. Now, I work in a unit where I do have the ability to treat if they did have acute stroke or something, you know, so for me I think, okay, I'm going to take that risk of going out of my usual environment to get the scan done. Even if our scan is 6 floors down in the dungeon, in the middle of nowhere, and I have no mobile reception, I'm going to take that risk. So I have to decide in my mind, because this patient's young and I want to know what they've got. So you have to decide. Okay, good. So really important for every time you do it. Right, so obviously I've talked about, you can go to different places, it could be different hospitals. Okay, now, we're talking about this lady, let's say she's 25, she's come in, she had a headache, husband found a headache, she was complaining of a headache and now she's collapsed, unconscious, she's been intubated. Okay, she's also a bit hypoxic, she's on about 50% oxygen, on the ventilator, her SATs are 94, so they're where they need to be. But she's on a lot of noradrenaline, okay, so I don't know what dosage you do, but I would say she's on, I would say moderate to significant dose, okay. But it gives her a blood pressure that's MAP of 65. What am I going to prepare to take this lady? So we've decided she needs a scan, because I think if she has something in her brain, like acute stroke or something, I know I have a team that can go and take the clot out. If she has an acute bleed, I might have neurosurgery here that can do something. So I do think that she has options for treatment that could make her better. So I've made a decision she needs to go for a scan. We need to decide, is this the right time to take her, or do we need to, is she a bit too unstable? I need to make her a little bit more stable before I take her. How many of you think we can make her a bit more stable before we take her? 2 of you, 3 of you, what would you do? How would you make her a bit more stable? What is your worry? Her blood pressure or her ventilation? Blood pressure, blood pressure. Everybody's worried about blood pressure. True, because the ventilation's not bad. You've got room to move. So her blood pressure's a concern. Why is it so low? Are we missing something else? And so I agree. I want to quickly look at her properly, thoroughly. Am I missing a bleeding lady who's bleeding somewhere else, or has she got really nasty sepsis that I've completely missed? Is it a meningitis that I need to really treat and do all those things? So I would probably try and spend a little bit of time to see if I can get her a little bit more stable, but at the same time not wait too long. There's only so much I can do. I can give her a bit of fluid, I can give her some antibiotics, I can make sure she's not bleeding. From clinical examination, there's probably not much else I can do, isn't it? And then I think, okay, I've had her now also, I've had her in the unit for about an hour and a half, 2 hours, and she hasn't got worse. So I think, okay, she might be a little bit better with the fluid I've given her. She's not worse, so we probably are in a window now we have to go if we're gonna go. Okay, so what are we gonna prepare for this lady? What do we need to prepare? So we need to prepare personnel, who's gonna take her. We need to prepare equipment, we need to prepare drugs, we need to make sure my radiologist is happy to do the scan, so I have to discuss and explain why I think it's necessary, and they have to agree, they have to have a space for her to come, or a slot, so I can actually go, so I have to do all those logistical stuff at the other end as well. Yeah? Okay, so tell me, what am I going to prepare in terms of personnel? Who do we need to do this transfer? Do you need a doctor? One doctor. Anybody else? One nurse. Could it be any doctor or any nurse that's just floating around? An ICU doctor or somebody who knows how to manage an airway and a sick patient. Good. What about the nurse? Does it need to be an ICU nurse? Excellent. Who knows how to use the pumps? Who knows how to troubleshoot a ventilator that you've just learned about this morning? Great. So we need at least 2 people. Do we need anybody else to help us get there? What was that? A porter. Exactly. You do need a porter, because me and you are busy. We're looking after the patient, we're looking at the numbers. I do not move beds very well. They hit the wall, they break the corners of the doors. I'm not good at driving a bed, and it's not our responsibility. Our responsibility is the patient, so you do need a porter. Okay, great. So you probably need 3 people. 2 clinical trained personnel, 1 porter. Okay, great. Equipment, what do we need? A portable monitor. Yes. With battery, because we don't have a PowerPoint along the way, so we have to have enough battery. Okay, what else? Sorry? Oxygen. How much oxygen? I know Maynard, who's just walked out, so there's a calculator. Oh, there he is at the back. Do you know how much oxygen we need? Do you take cylinders? How do you normally take oxygen? Cylinders. So how many cylinders? Small cylinders, isn't it? Yeah, we only have the little ones. You're going to take 1 full one? 1 big one? Okay, all right. Yeah, I mean, I take 2 little ones. If they're on anything more than, if they're on 50% and above, I obviously will take 2 cylinders, and they have to be full. Okay. But only because I know where my CT scanner is, and I know that when I get to CT, I can plug into the wall there. Okay, so I keep my cylinder just for transport. But if you're not sure whether you have oxygen down in your CT scanner or not, you're going to have to go cylinders all the way there, all the way back. You probably want a few extra. Yeah, so maybe, I don't know how your big one is, how much, but you definitely at least want a big one. Yeah? So there is a calculation that maybe Maynard can share later. Apparently there's a way of calculating how much oxygen you think you might need. Okay, depending on what your patient's oxygen requirements are, how far you're going to go in terms of duration. Okay, but that's important to know. You don't want to run out of oxygen. What else? Sorry? Vent, did you say? The ventilator, yeah. You need a portable ventilator, definitely. Nobody's bagging this patient all the way down. Sometimes people bring a patient from theatre, they've just bagged them down because it's like, 100 meters or less. And it's fine if your patient's otherwise on low FiO2 and you don't need to worry, but this patient's on 50%. If I start bagging her, I'm tied to the bed and I can't do anything else. And nobody's going to bag her all the way down, so a ventilator. With battery that is charged. Okay, good. What else? Drugs. What drugs? So your nurse has already got inotropes running. Do you want to take more, or you're happy with what she's got? More. You want to take a spare, don't you? Because you don't know when that's going to run out. Or when you go down and they become more unstable, suddenly you have to double the rate. That's going to finish really quickly. So often, I don't know what your pumps are like, but our pumps will tell us at this rate, you've got about 10 minutes left or 20 minutes left. Yeah, so often our pumps might tell us. And I always think if I'm going for a scan, that's a straightforward scan of the brain, the scanning itself takes about 10 minutes, but getting them on and off and all of that takes about half an hour. So I usually think at least an hour minimum. But if you're going anywhere further than, you know your environment, add extra time because you'd rather be safe than sorry. So drugs, I always take spare drugs. What else? Vasopressors, inotropes, yes. Other stuff as well. What else are we going to take? Cardiac monitor, we've talked about, yes. What other drugs? You said? Intubation drugs. Yeah. So what particular intubation drugs? Sedation, did you say? Yeah, your patient's now already sedated. They're unconscious and intubated, but they're on a bit of sedation, which doesn't make sense, but yes. Sedation drugs. What else? What else do you need to intubate? Muscle relaxant. I routinely take it. Purely if this patient suddenly starts to, what if she wakes up? It's great for her. Good news, she's waking up. I'm happy her brain is not so bad, but suddenly you can't get a good picture, or along the way she's pulling her tube out. So I'll take muscle relaxant. You can decide to give it before you go, or you can just take it and give it if you need it. Yeah? Okay. Anything else? She's quite unstable and we've already given her a bit of fluid. Do we want to take some with us? Yeah, we should take fluid. In case she drops a bundle again, blood pressure tanks again, I'm going to give her a bit more fluid. Okay? So probably the main drugs I'm going to take. We have a little transport bag as well. So anytime we leave the ICU, it's a mini bag that has a little bit of basic equipment, like an ambu bag, a little laryngoscope blade, a bougie and a spare tube, and it also has some emergency resus drugs like the small ampoule of adrenaline, and it has a couple of those drugs in there as well. So I don't routinely take adrenaline drawn up with me, but if my patient is unstable and I'm worried enough, I might drop a little ampoule, okay, of the double dilution. Okay, so she's been stable for 2 hours, I'm happy, I'm going to go without it, but you have to decide. But you need to take some adrenaline with you, just in case. Yeah? Good. Okay, so we talked about drugs, equipment, defib. Yeah. How many of you take a defib when you go out of the hospital? Yeah. Could be on the defib monitor. Yeah, exactly. So some monitors on the defib have the ability to do full monitoring and have defib ability as well. So if you have one of those, you're better off taking that because it does both. Yeah? If you don't have one of those, then you have to take a separate defib, which is a bit of a pain. And so it comes down to a judgment call. I don't take one all the time, but if there's some patients, like this lady, I might take it in. Another patient who's otherwise relatively stable, or not even on inotropes, I might not take it. But in this lady, I might take it. So that has to come separately as well, because we don't have those monitors with defibs on them. Yeah, good. Anything else? Equipment-wise, great, okay. So, I think we've talked about all of those things. Now the only thing I'm going to think is, before I leave the ICU, so in fact once I've made a decision my patient's got to go, I get the portable ventilator out, I put the patient on the ventilator, okay, while I do all the other things, which is get the nurse to set up all the drugs. I call the CT scanner, I ask them what time do you want me there, and then before I'm going to physically leave, you've got to make sure you call them again to make sure they're ready for you, okay. I ideally like my patient on a portable ventilator for at least half an hour. I want them on a portable ventilator for at least half an hour while I'm setting everything up, so that I know they have tolerated that ventilator, which is not your nice ICU ventilator, it's a more basic one, and they've not deteriorated, yeah? So if I'm happy their ventilation's not changed on the portable one, I'm ready to go, yeah? I quickly call the CT scanner, they're happy, they're ready for me, and we go. All right, so that's pretty much how I would prepare, and everything I prepared is also for anything that might go wrong. Okay, the only thing to say is if I'm now going to another hospital, now I realise she needs neurosurgery, and my neurosurgery is at a different hospital. What additional things I need to do, other than what we've talked about? Sorry? If now I should be fine, she's got a bleed in her brain, and she needs neurosurgery. Now neurosurgery for me is in a different hospital. It's about half an hour drive away. So now I have to transport her to a different hospital. What other additional stuff do I need to prepare or do for that to happen? Mannitol, yep, that's part of my treatment. Sure, if I'm worried about ICP, yep. But what about the transport stuff? Do I need to do anything else? Ambulance. You need to call the ambulance. You need to make sure it's the right ambulance to take a ventilated patient, yeah, because not all of ours can do that. The people that are coming with you who are able to, the paramedics are trained as well, okay. And it's going to be the same people going, me and the nurse, me and you are going, okay, and you need to have a paramedic. The paramedics need to know where to go. The hospital that you're going to needs to know you're coming. They have to say, yes, we're happy to take your patient. If they tell me I don't have a bed, sorry, not my problem, I'm going to have to find somebody else to go. So you have to make sure your hospital that you want to take the patient to is going to take your patient, and they're ready before you leave, okay? And that obviously the team knows how to get there. I think those are probably the main things. If en route anything were to happen, you have to decide. I might have to get the paramedics to pull over. If I have to re-intubate, you always get them to pull over, okay? Or if it's just, oh, a bit of drugs are running out, usually we're very vigilant. My nurse is telling me we've got 5 minutes, 10 minutes left. I've already drawn up some more drugs, and we go, okay? We're ready to change over. Okay, I think that pretty much covers most of these things. You need to check that you think you're the right person to go, and that also if you're leaving, you're the only doctor in your ICU, that your ICU that you're leaving behind has still got staff to look after the patients, okay? If you're the only person and nobody else can look after your very sick patients you've left behind, you need to find another way. You need to find somebody else to cover your ICU while you go away, okay? So really important. Know where you're going. Check they're ready. History. We always make a copy of the notes if we're taking a patient to a different hospital, okay? So that and the scans, we get it all on CD so that when we go there, they have the history of the notes, all the notes printed out, and they have the imaging as well. And we do a really good handover, which I'm not going to go over because Dr. Shumba's just done that, okay? So you need to know your patient that you're going to hand over. If I've just arrived on shift and they tell me I'm taking that patient now, I'm going to quickly read the notes. I need to get familiar, so when I go there, I've got a good handover to give them. Okay? And look at that. Oh, I can't go back. Error. I am pretty much done. It's not going to let me go back. Okay, not to worry. I was just going to say, I don't know if you saw that photo, there's loads of people. Okay, whenever you're transferring your patients, while you may go with the patient, when you're getting on and off tables, on and off ambulances, you need to have a few more people to help you roll the patient, make sure everything, your equipment's in place as you roll across, okay? So it often requires 4 or 5 people to do that, but oh no, what's happened? Okay, I think that pretty much finishes the talk. Have I missed anything? The weather, you can't do much about the weather. Okay. Yeah. Any questions? All good? Wonderful. They talk about a checklist. We love checklists in Australia and probably the UK ICUs. We love checklists. Everything has a checklist. It just means you don't miss anything. So if you have a transport bag, it may be worth having a little checklist on there so people know first what's in the bag, so you're not opening it for no reason, but also a little checklist of every time you take a patient somewhere, have I got what I need? And you quickly go through it. Okay, thank you. Maynard, what's that formula? What is this? Cylinder pressure. Oh my God, you might have to explain it. I don't even know it. Okay, you probably want to take a photo of this formula that Maynard here is going to explain how to calculate oxygen.
Is there a paper, empty paper?
Can you explain what it is though?
Yes.
Cylinder pressure.
Let's explain, huh? So we have so cylinder pressure. So different type of cylinders have a known pressure number. So the common oxygen container that we use, the big one, has 2000 psi. So it's called cylinder E. So every cylinder type has its pressure number and its factor number. So you're gonna take cylinder pressure times the factor of the cylinder divided by the oxygen consumption. You're gonna get the minutes that your cylinder will last. Hold on. So if you're using a oxygen container, the patient is on flow meter, maybe nasoprons 4 liters per minute. Your 4 liters per minute will be the oxygen consumption. So you take 2000 psi times the cylinder factor. Cylinder factor for E is 0.28 divided by 4 liters per minute. You get your minutes.
What if they're on a ventilator on 50%?
Yeah, so if they're on the ventilator, your oxygen consumption formula, you need to find the oxygen consumption for the patient who is on a ventilator. So for a ventilated patient, you're going to take the minute volume times the FiO2. So then you get your oxygen consumption. Times the FiO2. Yeah. And the FiO2 is in 0 point. Yeah. So if, for example, if it's 0.5, if it's 50% FiO2, it is 0.5. So 0.5 times the minute ventilation, maybe 6 liters per minute. So 6 times 0.5, you get 3. So you put 3 here down. And then you get your minutes. Yeah. So this formula helps you to calculate the duration of how much you're going to use your oxygen container when you're transporting your patient. So,
how much oxygen you're going to use for that transfer?
Yeah. So you can try putting some calculations. You're gonna try, for example, you're ventilating your patient, respiratory rate of 12
per hour, that would be
per minute. This is minute, yeah.
That's a minute.
Yeah. These are minutes.
So cylinder pressure is a standard 2000.
Yeah, it's a standard 2000 depending on the container type you're using. If you're gonna use those small containers, I think that a D or something, you can actually check and see the pressure. Yeah. Yeah. They're in PSI pressures.
The thing is like the tank is pressurized.
Yeah.
So the oxygen is not put in; it has to be put with the pressure. So it's like a balloon. If you inflate the balloon, so you have to push a pressure to inflate the balloon, and when you release, so it comes with the pressure. So this.
So there is another formula that use Boy's law, where you use the volume. Yeah, but that one is quite complicated compared to this. This one is very simple when you have the cylinder pressure, the factor, and the oxygen consumption. Bus. Yeah, for the cylinder type.
Table, cylinder type,
Yeah.
and how long you use, if you use particulars as that leaves. Very important.
Any questions about that formula, guys?
Yeah.
The cylinder pressure,
No, yeah, they are constant. Just know the type of the cylinder that they are giving you. So, mostly that we use here, the longer ones, are the cylinder E, type E. But we have the smaller ones that our ambulances love to transport patients with. Those are very small cylinders. So be very careful. Those cylinders will eventually finish even you haven't reached Morogoro. I'm telling you. Yeah? So once you know the type of the cylinder, the factor is there. So there's a table that Dr. Rama will show you. But then it's a standard number. It's a standard number that you can always Google it, you have it there. It's cylinder type, it's factor type.
So H is the little one?
Yeah?
H is the little one.
H, yeah, with factor 3.14.
The little cylinder.
No, I'm not sure with the pressure. Yeah. I'm not sure with the pressure that it has.
That's okay, but is it the little cylinder H?
No. Yeah.
Here's these are MME. So these are the cylinder types.
Oh yeah. So you can see here, guys, when you Google it, you can see the cylinder types. Yeah.
So you
Yeah.
Google or look on your actual cylinder, you go ask the cylinder, and then look up the factor.
So the tricky part is how to find the oxygen consumption. It differs to a patient ambaye on a flow meter and to a patient on mechanical ventilation. So it differs. For mechanical ventilator, you have to use minute volume times your FiO2. For a patient on spontaneous breath, use the flow liters. Minutes. Yeah, so you get the minutes that the cylinder will last. Minute ventilation, respiratory rate times the tidal volume. Yeah, and your tidal volume, you put it into liters. So if it's 500 mils tidal volume, it is 0.5 liters.
Guys, I understand we may not have transport ventilators in our units. I don't know, in Mananyamala, do you have transport ventilators? Yes. You have transport ventilators? Portable ones. Where you don't have transport ventilators and you have to take the patient from intubating the patient to CT scan, what do you do? Okay. So you go with the ventilator? Okay. So have you ever had that situation where the patient is intubated and you have to bag the patient to CT scan or something like that? Have you ever had that situation? The idea I'm bringing in is the bagging process. Because when the patient is connected to ventilator, you set a PEEP, right? And then when you disconnect from ventilator into your bag, this bag has to have a PEEP valve. And we don't have those PEEP valves. Do we have them? We don't have. Do we have the PEEP valve? So what does it mean? If the patient had a PEEP of 7, the tube is in. If you don't have that bag, it means that PEEP is distorted. That patient doesn't have a PEEP anymore.
you asking me what to do?
No, I'm just saying if you agree with that. Yes.
I was like, I'm not in that situation normally, but yeah. So yeah, if you have a PEEP valve, you should use it. I mean, I don't know, there is a Waters Mapleson circuit on there, that I saw yesterday on the actual table. But if you don't have a Mapleson circuit, do you just use an ambu bag?
Yes.
Okay. So if you have an ambu bag, even ambu bags do occasionally have PEEP valves, but if you don't have a PEEP valve, well then you have to just go without PEEP.
Yeah.
Basically. Yeah.
How would you able to run?
You can't. Oh, well, true. So, I have done it purely because I ran out of oxygen once, and it's not what I would recommend. So I have had to be in the scanner before. You have to wear the lead, and then you have to bag, keep the oxygen up, quickly out, come back in if you can. But obviously, you can only do it if your patient's stable. Otherwise, you can't do it. You can't bag in the scanner while the scan is happening, especially for the brain, because that's where the tube is. You physically can't do it. Yeah. So you have to be able to have your patient apneic for the time of the scan. And if it's a brain scan, our scanners usually do them in 5 minutes or less. And you can quickly interrupt if you have to at the halfway mark to give a few breaths and then they carry on. But if it's not possible, that means you just can't do the scan. Yeah. So that's part of your planning. If I don't have a portable ventilator, they're on a lot of oxygen, they need a brain scan, I can't bag them all the way there, then you probably can't do the scan. Yeah. Ramadan, did you have a point about the PEEP? Was there anything else you wanted to say? He's not listening. Was there anything you wanted to say about the PEEP? Yeah. Okay, but they do come with PEEP valves. So ambu bags do have PEEP valves as well these days, so you can attach a PEEP valve onto it, which means at least the best you're giving your patient is a bit of CPAP when you take them down. If you have a PEEP valve, it's better than nothing. Yeah. Anything you wanted to add? Okay, we'll wait for him to find what he's looking for, and then after this, we are going to split into groups for the skill stations. I think there's only 3 stations today, so we're going to split into 3 groups. You okay, Ramadan? He can't find it. How about we do it at the station, Ramadan? Did you want to talk to him about something? Yeah? Okay, so should we split up? Should we split up? You'll show them? Yeah. Should we split up? You want? Okay. Yeah. There is. So we have to split into 3 groups. So if you just go 1, 2, 3, like you did yesterday. Yeah? 3 groups? Can you divide?
3 groups, so 1 to 3. And there? 2. 3. 3. 2. 3.
1. 1.
Okay. So 3 groups. We man vascular access. We have the troubleshooting and the transport. The session is transport, eh?
Transport?
Yeah. So this one will be transport. Ali? Moja kutumia vile pale kama transport. Nani? Troubleshooting hapa kwa transport.
Ile ni nzuri.
Tunazo vingi nataka kuonyesha vitu. Tunatumia kwenye transport. Nani ndio mwenye hiyo ina. This is vascular access. We can just say one.
Just one group, one more come here.
Group 1 there, group 2 hapa, group 3 back.
Anesthesia, flow.
It's still for pressure. But how much?
How much in there? He's okay.
He's
you.